Thank you, Henri, and I would also like to truly thank the French Academy for inviting members of the American Surgical to make these presentations. I've enjoyed all the talks, and I apologize if I'm going to be giving you some basic science work that we have been doing, but it does clearly relate to the advancement of utilizing more donors in liver transplantation. So the topic of my discussion is how we are able, or how we should, prevent ischemia reperfusion injury, which is truly one of the rate-limiting steps in expanding the donor pool. The importance of this topic is the fact that all transplants are dependent on donors, and the number of donors do not fulfill the requirement of patients who need transplants. In fact, if we look specifically at liver transplantation, almost 30% of the recipients will die on the waiting list because of the lack of a suitable donor. Thus, donor scarcity is clearly one of the paramount problems that we face in organ transplantation. Now, this shows you graphically what I have just stated. Over the last 22 years, the waiting list for livers has increased 12-fold. The number of transplants has only increased about 2.5 times, whereas the deaths on the waiting list have increased 6-fold. So it clearly is a significant problem that we have to face. Now, what we are now doing is that we are using what we call extended criteria donors, which means that we are taking organs from less than ideal donors. 25 years ago, basically all the donors that we had were quote unquote ideal because we didn't have that many people on the waiting list, and thus we would be able to wait until we selected a donor. Where today that is not the case. So what is an extended donor? An extended donor is a donor that has an organ that has a significant risk of early failure. And there are several factors that determine whether a liver will fail. Many of them are purely donor factors, such as fat content, the age of the donor, the length of time that the donor is in the hospital before brain death is declared, or if that donor happens to be what we call a donation after cardiac death. There are also technical factors, the overall conduct of the operation, the warm ischemia time, how long it takes you to put the organ in from the time that the organ is preserved, cold ischemia time, how long the organ is in an ice bucket. And many surgeons will discard organs when they see them because they think that they are really not suitable. So our goal was to see if we could convert an extended criteria organ to one that would work. This shows you the total U.S. donors over the last 9 years, and you can see that although we have had an increase in donors, most of these donors that have resulted in this increase have been characterized as non-ideal or marginal donors. And in fact, this slide shows it very graphically from 2010. There were a total of 6,600 livers that were recovered. 675 were thrown away, weren't even used. And that's over 10%. So what is the future goal? The future goal is to try to take one of these high-risk donors, to manipulate them in some way, and allow them to function properly. And this is something that our laboratory has been engaged in for over a decade. The emerging technologies that are now available are outlined very briefly here. And they basically involved either donor or graft treatment options. One that has not had any significant application to the clinical situation, which we are very interested in, is how to modulate actual T cells. And we feel that if we can modulate certain families of T cells and block the toll-like receptors of T4 cells, that we may be able to significantly advantage organ function. The other is to actually treat the donor organ. And that's what I'm going to focus on right now. And I will show you some of the basic science work that we have done, and also show you how that basic science work has now been translated into a randomized controlled clinical trial, and I'll show you the results of that. This is what happens when an organ has been stored in ice and then is reperfused. And basically, let me go through this with you very, very briefly here. The first thing that happens when blood is turned on to the hepatic sinusoid, and this is the hepatic sinusoid with hepatocytes, endothelial cells, as soon as the blood is restored to the organ, the first thing that occurs is the liberation of multiple reactive oxygen intermediates. Once this is accomplished, Kupffer cells are activated and adhesion molecules are activated. With the adhesion molecules, and the selectins are the one group of adhesion molecules that are activated first, there is a cascade of events that results in a clumping of T cells, PMNs, and platelets to the endothelial cells. And as a result of that, blood cannot get through. In addition, there is this liberation of these chemokines and cytokines, such as IL-1, IL-8, et cetera, that results in significant organ damage. Now, just about 3 months ago, I happened to have been in Valencia, Spain, at a liver meeting, and my wife, we were on the 10th floor of the hotel, and she looks out the window and she says, "This is what you're going to be talking about." And I say, "What do you mean?" She says, "Look at the freeway." And sure enough, outside of our window, this is the freeway. This is a sinusoid that is having significant ischemia reperfusion injury. The blood can't get through. Whereas this is a sinusoid in which it has been protected and the blood gets through. I apologize for this, but I thought it was very interesting and I thought I had to show it to you. So one of the technologies that we have been studying, as I say, for over a decade, is trying to block selectin activation. And for selectins to be activated, they have to bind to a ligand, and the ligand is p-selectin, is PSGLIG. So the ligand has to bind for the selectin, and when it does that, it clumps to the endothelial cell. If you can block the ligand, you may be able to block this clumping phenomenon. And this is exactly what happens. Here you have an activated endothelial cell that, when activated, upregulates both p-selectin, which is made, and e-selectin, which is constituently in the endothelial cell. This then binds to PSGL1, the ligand, and this causes the PMNs, polynuclear leukocytes, to clump to the endothelial cell. P-selectin also resides within activated platelets. These also clump, as do leukocytes. So, if we can block this ligand with our PSGL1IG, can we prevent, to some degree, ischemia reperfusion injury? The first group of studies that we did is with an animal model, a obese Zucker rat. And why did we choose that? Because, as I mentioned to you before, one of the critical elements of donor dysfunction is if the livers have a lot of fat. Well, these Zucker rats constituently have a large amount of macrovesicular steatosis, macrofat, in the liver. And this is a fatty Zucker rat. You can see his liver is filled with fat. This is a lean Zucker rat, and you can see that the photomicrograph of his liver is relatively normal. So this is the model that we first chose. And what we did, and we did this in a series of experiments. We first started out with isolated, perfused livers, et cetera. I'm not going to show you all of that, but then we went to an actual transplant of these animals. And basically, this is the fatty Zucker rat. We remove the liver, we store it for a few hours in cold storage, and then we transplant it into a lean Zucker recipient. So you don't need immunosuppression. This is a syngeneic combination. And we randomized them into two groups. In one, we treated the liver after it was removed with the RPSGL1IG, which is the blocker of the ligand. And in the other, we just used a placebo. And then we did the transplants. And these are the results. This is the group of animals that were treated by selectin blockade. 14-day survival was 90%. Those of the controls, 14-day survival was less than 40%. And then we looked at various parameters as you would anticipate, and you can see that the experimental animals had a lower SGOT at days 1, 7, and 14. If you look at biomarkers, and these are harmful biomarkers, TNF-alpha, IL-1, IL-6, gamma interferon, IL-2, in all of these, those that were treated with the selectin blockade had significantly less injurious biomarkers. The experimental animals are shown in green, or the controls are shown in yellow. If you look at the biopsies, we could see a profound difference. These are the control animals, and you can see the typical zone 3 knockout, which you see. This is a central vein. And if you look at a human liver, it looks exactly the same way if there's IR injury. And these are the animals that were treated with the selectin blockade. The biopsy looks relatively normal. It's not completely normal, but it's certainly improved over the control animal. We also wanted to know, if you block IR injury, if you could also decrease the allogeneic response and therefore decrease rejection. So in this group of experiments, we took a DA donor and put it into a Lewis recipient, an allogeneic combination, did the same type of orthotopic liver transplant, but because we did not use a fatty liver, we could store the liver for 24 hours. If you will recall, in the fatty grafts, they wouldn't last more than 4 hours. And we divided this into 4 groups. One, we didn't do anything to them. In the second, we gave only the selectin blockade. In the third, we blocked the immune system with cyclosporin. And in the fourth group, we blocked IR injury with selectin blockade and also gave low-dose immunosuppression. And these are the results. If you do nothing, in the control animals, they only live for about 12 days. In the animals in which you just block IR injury, their length of survival is extended to 18 days because they all reject eventually. If you give just cyclosporin, you can extend the survival up to about 30 days because you block the immune response. However, if you block the ischemia reperfusion injury and then give low-dose immunosuppression, the survival of the animals is 90% long-term. So there is no question that there is a correlation between the ischemia reperfusion injury that occurs during harvesting of the organ and preservation of the organ and the eventual allogeneic response that occurs afterwards. And this shows you those 4 groups. You can see this is the controls, look terrible. The ones in which you have selectin blockade look a little bit better, but they don't look very good. Those that have short-term cyclosporin look about the same as the PSGL1, and the best photomicrograph of liver biopsies are those in which you block both the IR injury and you block the allogeneic response. So from these animal studies, we found that by blocking the selectins, that you could decrease neutrophil infiltration, you could maintain hepatocyte integrity, you clearly could block IR injury, and you could improve graft survival in an experimental liver model. Now, these studies were reproduced in all other types of transplants, in kidney transplants, intestinal transplants, heart transplants. In all of these animal studies, we could block IR injury and decrease the injury and improve survival. So it was time to move on to a clinical trial. And this is a phase 2 randomized control blinded study looking at selectin blockade in human orthotopic liver transplants. And basically what we did is we randomized patients who were candidates for liver transplantation to either be in a placebo group or to have selectin blockade. And the way this was done is that the organ was harvested, and once the organ was harvested, it was either flushed on the back table with placebo via span, or it was flushed with the selectin ligand blocker, YSPSL. And this was given at the time of organ harvest and then 1 hour prior to arterial reperfusion in the patient. And we did this in 47 liver recipients, and I basically did all of the operations because I thought it would be important to have consistency in the operative technique, because that obviously might very well alter the results if you did not have that. So these are the results. These are the average of all liver function tests between the two groups. The green group represents those that receive the PSGL1 IG blocker. The red group represents the placebo. And if you look at all of the various routine liver function tests that one takes, SGOT, SGPT, area under the curve, maximum enzyme production, bilirubin, etc., there was improvement in those patients that received the PSGL1 IG, the selectin blocker, versus those that got the placebo. Let's look at this a little bit more granularly. There were 23 patients in each arm. This is those that received selectin blockade. This is those that received placebo. This is all comers. You can see that there was no difference in death or graft loss between the two. Only one patient in each group died. There was a higher incidence of initial poor graft function in the placebo group. This did not achieve statistical significance because the power of the study. There was also a lower SGOT in the selectin blockade, and because of the power of the study, this was not statistically significant, and this is all comers. However, if you look at those patients that got high-risk grafts, and we have a mathematical formula which has been published, not we, UNOS, and United Network of Organ Sharing, which is called the Donor Risk Index. And if you look at those patients that had the donors that had a high donor risk index, defined as greater than 1.55, and then you look at the two groups. There were 9 patients that got the selectin blockade, death or graft loss 1. In the 12 that got the placebo, 0, not significant. If you look at initial poor graft function, 45% of the placebo had initial poor graft function, approaching statistical significance, p-value 0.09. And if you look at normalization of transaminases, statistically improved in those that got selectin blockade versus those that got the placebo. And if you look at both protective cytokines and those cytokines that promote ischemia reperfusion injury, this is IL-10, which is a protective cytokine, significantly increased in those that got our PSGL1 IG selectin blockade versus the placebo. And if you look at IP-10, promotes ischemia reperfusion injury, significantly decreased in the selectin blockade group. So, in summary, this phase 2 study shows that selectin blockade is safe. We were concerned that perhaps it may cause bleeding. It did not. It is the first clinical trial to demonstrate a beneficial effect of adhesion molecule antagonist in ischemia reperfusion injury in the liver, and it exerts the most beneficial effect in those grafts that were considered high-risk grafts. And this study is now the platform for a multi-center randomized controlled trial to see if selectin blockade can significantly ameliorate IRI injury in liver grafts. Thank you very much.
Thank you, Ron, for this very exciting work. I agree with you. This is the main problem of organ transplantation. If to have the donor, one day I said it's a joke that the most important complication of organ transplantation, mainly liver transplantation, is not to have a donor. For this is more lethal in 100%, of course. So now I have one question for you. Are you the only team that will use this PSLG blocker, or all of them? This is my first question, and all of the groups. And the second one, if you accept a discard liver, that means a bad quality liver, and are you always on the turn roll, the turn list? I ask the question for this reason. In our center in Paul Brousse, we offer a liver according to a turn among the 7 liver transplantation group in Paris. And if we accept a liver, we lose our turn. That means we will go on the beginning. When there is a bad quality liver, it happens that most of the team reject the liver. As we have many patients, we accept the liver. And then we lose our turn. At that time, we are almost always accepting bad quality liver. And this is a penalty for the large group to use this kind of graft. How do you manage to solve this problem?
Thank you, Henri. The first question is, what other centers have looked at this? The Boston group, Nick Tilney's group, was actually the first to look at selectin blockade in an experimental animal. They did it in kidney transplants. So other groups have done it, and in fact, there has been a clinical kidney trial in which selectin blockade was looked at, and that was published about a year or so ago. Your second question regarding the penalty that one pays when discarding or rejecting a liver. As you know, our system is a little bit different, but I think you have now adopted the MELD system. Mm-hmm. So we basically get an organ offer based on the severity of illness of the patient. Sure. And so, I'm not going to talk about my center, but in Southern California, the number of recipients far exceeds the number of donors that are available. In fact, when you look at a MELD score, and the MELD goes from 0 to 40, 40 being the highest, the mean MELD score that we are transplanting is around 35. In other parts of the country, if they transplant somebody over 17, that'll be a lot. So in any event, we don't really have the luxury of turning down many organs, because if we don't attempt, even though if we have a 20% chance of that organ not working, we know that if we turn that organ down, the likelihood of the patient dying is very, very high. Mm-hmm. On the other hand, in the States, everything is monitored very, very carefully. Everybody knows how every center is doing. Mm-hmm. Everybody knows what every center's results are. Mm-hmm. And so you have to be careful, because if you go out and you extend your criteria and then your results aren't very good, you may have some major problems when they review you every 6 months and they say, well, my center isn't doing, your center's not doing as well, and then the insurance companies start to call you up and they say, I don't think I want you to do organ transplants for me, even though you're doing the sickest ones in the group, et cetera. So it's problematic.
Thank you. Thank you.
Yes, yes.
We have the same problem.
Take the microphone, please. 1 minute.
We have the same problem in the severely shocked patient from trauma. And reperfusion injury is almost 100% in the lung.
Yes.
And you see it also in the liver. The uniqueness, though, of the liver is the reperfusion is coming from the gut. And in the lung, it's coming from the skeletal muscle and the torso, what have you. We showed several years ago that you can block it just as you did. We used scavenger stuff for the free radicals.
Free radical scavengers.
Yeah, and selectants. And the bottom line is there some way that you could, in these high-risk donors, could you start them on an SMA drip of these things prior to even taking out their liver?
Right. That's a very good question. And in fact, we had initially wanted to give the donors the ligand blocker intravenously. However, because we were dealing with multiple organ donors, we weren't really allowed to do that. But that would be the ideal way of doing it, is to give them that a priori rather than waiting until the organ is out, as we have had to do. And I would bet that that would probably result in better results than just infusing the organ after the organ is out and has already suffered significant, even more anoxia.
Any other question? No?
Thank you very much.
Thank you, Ron. I think that we end the session. We organize a small reception before we leave, and I think just out of the room we have some wine and cheese, as it is, I think, usual when we finish this kind of session. Thank you a lot for your coming.